I'd like to say that we don't have to do an internal exam. If somebody did not want to do an internal exam, what I would do is have them lay either on their back or on their side. And I can, again, with a gloved hand and with underwear on, clothes on, I can sort of palpate from the outside. I can feel where there's tension, where there's good flexibility, and I can envision in my mind like where the muscles are. I can feel all of that externally. So if I am doing an internal exam with somebody, I'm teaching them how to breathe first. I put them in a very comfortable position so their legs are comfortable, their back is comfortable so that they're not holding any tension anywhere. And then with a gloved hand, I'm going to palpate on the outside just to see what I can feel. And then insert a finger, and then I will test, right and left side. And basically, I'm testing all three layers of the muscle, asking them if anything hurts, if any of my pressure is relieving some of the pain that they're having, and I'm testing the strength. So that's basically the exam, the internal exam part of it. That's also part of the treatments.
What's up, everyone? Welcome to the Health Class She Deserves, the show where we ditch outdated women's health myths and talk real bodies, real cycles, and real stories. I'm your host, Autumn Payon, and today we have episode number 5 in our endometriosis series with Ellie Sara. If you missed the first 2 installments, go check them out for a deeper dive into endometriosis. I'll link them in the show notes. In today's class, we are welcoming pelvic floor physical therapist Rachelle Bojer. Rachelle has been practicing physical therapy for over 20 years. She's passionate about women's health and wellness, specializing in pelvic floor dysfunction. Rachelle founded Lotus Physical Therapy in New York and collaborates with Ellie Sara Medical to work closely with patients navigating pelvic health concerns and endometriosis care. Rachelle, welcome to class.
Thanks for having me. I'm very excited to be here.
I'm excited to have you. And I was realizing as I read that I didn't confirm how to say your last name. Did I say it correctly?
Hey, it's Rachelle Bojer.
Bojer, okay. I was like, I don't know. Is it French? I'm not sure.
Fancy, so it's all good.
Okay, cool. Well, I would love to start with a little bit of your background. It's been a bit of like a common theme with this Ellie Sara series, like talking to Dr. George and Dr. Katie. They both were kind of like, did not go into this field with endometriosis in mind at all, didn't necessarily know much about it. Was that your experience too?
Yeah, so I'm a physical therapist trained. I got my license about 25 years ago, and I got into the field originally doing sports and orthopedics. I loved it. I still love it. And a lot of what we do in pelvic floor is orthopedic related, obviously. And, I think you become interested in what you're going through in your own life, right? So once I had always had an interest in women's health, and I always took extra classes to help women in pregnancy and postpartum. But then when I had my own experience as a pregnant mom of twins, I was really able to put to use all of the things that I had learned in my training. And then after my twins were born and I didn't want to commute an hour to work, I decided to open up my own practice and just specialize specifically in women's health. And originally, my thought was to just help women prepare for birth and rehab after birth, because there is really such a missing piece to the rehabilitation there. But as people started to come to our practice, we found that women were coming for all different sorts of, pain diagnoses, including endometriosis. So I had met Nikki a few years ago and we connected, and I learned so much from her. We're still continuing to learn from her and her practice. So it sort of evolved, and now we see all different aspects of pelvic floor therapy, and endometriosis happens to be one of them. So it's just so multifaceted. And as you know, you've already interviewed a couple of other providers. It really does need a whole team approach. So not just a functional medicine piece and figuring out what's going on metabolically with the patient, but then how can we then manage their pain? So I take care of the physical part, when our bodies are in pain chronically or, even acutely. It's almost like the brain is telling the muscle to be in fight or flight at all times. So it's very difficult for the muscle to then relax back to its natural state of resting because it's always contracted, it's always tense. So, someone like an acupuncturist or a mental health therapist or an energy healer can help with the emotional part of it and the energetic part of it, but I work on the physical part.
I love that too, that you say that. And I definitely want to dive into the nervous system side of things a little bit later. But it's one of those things where I think a lot of people don't think of it as the physical. Like they're often thinking that emotional side or the less tangible side.
Yeah.
And I think that makes it less real for people. But as us as endometriosis patients, like I know it is so physical, and the state of your nervous system and being in fight or flight all the time
Right.
affects so much physically. So you kind of touched on this a little bit, but I guess let's just, you know, for people who maybe aren't entirely sure what pelvic floor physical therapy is or who it's for, because as you mentioned, you originally were focused a little bit more on, sports at first and then like pregnant people and postpartum. And I think that's a big misconception
Yeah.
that pelvic floor PT is like only for postpartum mothers and for giving birth. So can you like unpack why that's not true?
Definitely. Okay, so what I'd like to do is kind of like go over what exactly the pelvic floor is. So everyone has it. Every human being has a pelvic floor. So whether you're an infant or you're 99 years old, we all have a pelvic floor. So basically, when we look at our pelvis, right, we have these bony structures. So we have our hips here, and then we have our spine, our sacrum, our tailbone. So when we use the term pelvic floor, what we're referring to are the muscles basically that are at the base of the pelvis. And as you can see here, we have several layers of muscles, right? So it became very, it's like, who's going to treat this part of the body? Physical therapists are the musculoskeletal experts, right? So it kind of made sense that we would be the ones, physical and occupational therapists would be the professionals that would treat this area. But just because it's in this private area doesn't mean that it doesn't act like a regular muscle. So these muscles can be strong, they can be weak, they can be tight, they can be flexible. I can press in different spots here, and it could be very painful. So we can have trigger points in this area. So I always say it's just like your quad or your deltoid or your hamstring. It just happens to be in this area, right? And so when we do an evaluation, we do a whole evaluation for posture, strength, flexibility, but we're specifically trained to do internal examinations. It's very different than a gynecological exam. We don't use speculums, but what we're looking for is integrity of the tissue, if there's any scarring from surgery or trauma. Is the muscle strength there? We still grade it the same as we would like a shoulder or a knee. Is there flexibility in the muscle? Is it hypertonic? Is it low tone? So I think the misconception is that pelvic floor therapy became a little bit more popular because we do prepare pregnant women to have their babies and then to rehab them after. But the truth is, because every human being has a pelvic floor, little kids can have pelvic floor dysfunction. So that can look like bedwetting, that could look like constipation, and that could look like losing control of urine or feces as a young child during exercise or during activity, and then going through the lifespan, as young girls get their period, right? So there could be period pain, cramping. I'm getting a ton of patients that are saying that during their cycle, they're getting so sick from the pain that they're actually throwing up and they can't go to work, they can't go to school.
Yep.
Right? And
That's me.
so what ends up happening is you go to the gynecologist and they're like, "Oh, let's put you on birth control." That has become sort of the norm in treating irregular periods when, now, I'm going to jump a little bit, midlife women are having a moment, menopause, perimenopause women are having a moment. And, now everyone's talking like, "Oh, I got to test my hormones, test my hormones." Why aren't we testing hormones in teenagers that are having bad periods or painful periods, irregular periods? Why aren't we testing them? And instead, we're giving them this quick fix, take a birth control pill, and that should fix your problem. But then fast forward to their 20s or 30s, they're trying to have a baby, and sometimes it's a challenge. So in that age range, right, I'm seeing a lot of pain patients. So sitting at work, they have tailbone pain, they have pain when they exercise, they have pain when they have intercourse, they have pain during their periods. And then when we go into childbirth age or childbearing age, right, we're preparing their bodies for pregnancy, rehabbing them after having babies, which I think is an important piece. And then as we get older, we get into midlife and perimenopause and all the fun changes that happen during this period of time. So then we're dealing with frequent UTIs, stress incontinence, prolapse, painful intercourse. So it's, different things there. And we also treat constipation through the lifespan. We treat men, we treat children, because everyone has a pelvic floor, it can present differently at different stages of life, but still at the end of the day, it's muscular. It's part of this orthopedic, musculoskeletal system. So we have to check this whole system to make sure that it functions properly.
Mm-hmm. Yes, there's so much I want to unpack there. I love how you mentioned like it's really everyone has a pelvic floor and it's really any age, because I think one of the most common misconceptions with endometriosis is that it's a problem that like only starts presenting itself or can only start growing once you go through puberty, and we know that's not true. And the majority of endometriosis patients would be able to tell you they had all these symptoms in childhood that just were never linked. And in hindsight, they're like, oh my God, so like constipation and like you said, bedwetting, like that was one that I recently came because I wet the bed until an alarming age. And I was just talking about it on my TikTok a few weeks ago because I was like, does any other endometriosis patient relate to this? Because I wonder if this had anything to do with the inflammation, pelvic floor dysfunction related to this disease. And there were quite a few other people that were like, oh my God, yeah, like me too. So
Yeah.
it's really I'm glad that pelvic floor physical therapy is having a bit more of a moment. I definitely see more people online like talking about it. And you mentioned quite a few symptoms there that pelvic floor therapy can help
Yeah.
with a lot.
I think what happens is because it's in this private area, right? In our culture, it's so taboo to talk
Mm-hmm.
about anything below the waist, right?
Yes.
And so I think that, if we could start educating our young people earlier, boys and girls, teach them about their anatomy, proper names for their anatomy. How does their body work? We need to have them learn what, the opposite
Mm-hmm.
pelvic floor is doing,
Mm-hmm.
right? So that as they get into teenage years and young adulthood and they're, possibly having their first, sexual encounters, that they're educated not only about their own body, but they're educated about the other person's body, knowing about cycles. Nobody knows. No, it's so sad to me when I have a patient that's in their 30s, 40s, 50s. They don't know what a hormone is, but they do hear, estrogen, progesterone, testosterone, and they think they know what it is, but they don't really know what a hormone is doing, and no one is really explaining to us how our bodies are working. And our periods, our menstrual cycle is a very, very important piece to our health and our longevity. So, I'm so happy now that we're at this stage where it is getting a lot of, attention, because I think something has to change. There is a missing piece of education so that when we're in our 30s, 40s, 50s, we're not like, I have no idea. Nobody ever told me, right? So it makes me so sad when I have a woman that'll come in and say, well, sex has always hurt. I didn't even really know it was supposed to feel good. How can that happen in the United States in 2026? That a woman is
Mm-hmm.
50 years old and has no idea that sex was supposed to actually feel good, right? So I
Mm-hmm.
think there's definitely some missing pieces there. And I know with my endometriosis patients, they have a lot of pain with intimacy and they're scared to even explore down there on their own because of the pain. So that's a real piece of, life that we have to address, and people don't feel comfortable talking about it. And then who do you go to talk
Mm-hmm.
about it with? Gynecologists don't have the time to discuss sexual health or pain, right? So then they'll pass you off to the next, to the next, to the next. So it's nice
Yeah.
that Elisara has this wellness center where you can kind of go and see everybody there together and get this whole team approach to be able to work with their endometriosis symptoms.
Yes, absolutely. Because it's a systemic disease and it affects
Right.
everything in the body. And so having that like group, the multidisciplinary approach is so much more effective for patients than just one thing. And like you said, like gynecologists don't always have the time. And even when you get in with like a really high quality surgeon to do your excision surgery, that's their job. A lot of times the aftercare for that isn't always, they don't have time for that either. Like they're so overworked already. We have such a shortage of those types of surgeons. And so
Right.
it is really important to have this multidisciplinary approach. And like you said, like the pain with intimacy and having painful sex and women not knowing that it's supposed to feel good or how good it can feel, like it is so, so sad.
Yeah.
And there are people, like I get a lot of comments on my social media accounts with people telling me that their doctors told them that they were just supposed to feel pain with sex as a woman or as the person with the vagina in this situation, that sometimes they just, that happens and they just have to deal with it. And I'm like, no,
Yeah.
there's a reason for it. And there are things you can do that could potentially help. It's
You know what I
sad.
always say to people? That's so frustrating to hear that, because many times, I'll have a client that gets dismissed by their healthcare provider, and that's so unfair, right? But you go to these people because you trust them, right? They have a certain degree, certain training, so you are trusting that what they are saying to you is the right thing. But when you hear, "Sorry, sweetheart, that's what happens when you have a baby," or "That's what happens, it's supposed to feel painful. Too bad, you're peeing yourself. Too bad, that's what's supposed to happen." I always say, you know your body and you know how it's supposed to function. Normal function is that we are able to hold our pee, hold our poop until we get to the toilet. If anything else is happening aside from that, if you're leaking, if things are coming out when they're not supposed to be coming out, if it's painful, if you're having trouble getting it out, that's not normal function. So keep going and keep finding the provider that is actually going to listen to you, because that "sorry, sweetheart, that's how it is just not, it's not acceptable at all. And so we have to make sure, again, education, we educate people about their body so that they know, well, it's not supposed to hurt. So what can I do if it's painful? Do you have any other suggestions for me? And if they don't, then you can move on to another.
Yes, exactly. Yeah, the normalization of women's pain is appalling, and the amount that it comes from the people, like you said, that you go to because you trust or you want to trust them. You're supposed to be able to trust them, and they're trying to normalize pain. Like pain is always your body's way of saying, "Hey,
Something's
something's
going on.
wrong. Yeah,
Yeah.
we got to address something here." Can you talk a little bit about how pelvic floor physical therapy, how you actually do work with patients on that type of pain?
Sure. So when someone first comes in with pain, we take a thorough history, find out, what has led up to the level of pain that they're having. And then we try to figure out, why is that pain happening? Is it, because muscles are tight? Is it because the posture is off? Is it because strength isn't there? Is there scar tissue? So we do a full assessment of all of that before we even, get somebody on the table. And then most of us are trained extensively in manual therapy. So we'll get the patient on the table, we'll start to feel around in the abdomen or areas of pain, see if there's any restriction in the tissue. We'll do an internal exam to see if the pelvic floor has any, is hypertonic or has any tightness or spasm, scar tissue, anything like that. And then we are trained to do the manual therapy to help release tissues so that there's appropriate blood flow, appropriate movement, right? So our bodies are made to go along with movement. But if we're stuck somewhere or we have adhesions, inflammation, scar tissue, and we can't move, that's where the pain comes in. And then we also teach our patients about downtraining our nervous system. That also is like a buzzword these days, right? Because we're all so busy, we're always on our devices, on our phones and everything, right? Our nervous systems are always so hyped up. And when you're in pain, your nervous system stays in that state permanently. So what we have to do is teach people, how to breathe, right? Sometimes just teaching people how to exhale, because they forget they're constantly in this, and they're like, they're holding their breath, they're holding their abs in, they're, constantly, they're tight everywhere. So we always start with teaching people how to breathe properly, right? If you watch a baby breathe on their back, you'll see that their belly rises and falls. And then somewhere along the line, as we become adults, we start to chest breathe, right? So if I said to you, take a deep breath in, most people would do this and breathe into their upper chest. So we try to slow everything down, teach them how to breathe like a baby, breathe into the abdomen, expand, and then, exhale just as long as you inhale, right? We forget sometimes people do like this quick exhale. And, there are different techniques that you can do to help, regulate your nervous system. But I always tell people, like, find what works for you. If you're like an outdoorsy person, get outside, walk in the grass barefoot, walk in the sand, get your feet in water, really ground yourself if that calls to you. Sometimes people like the gadgets. They like the red light, they like the sauna, they like the cold plunge, they like the vibration plates, they like sound bowl healing. I think that people have to find what really resonates with them and do that practice, weekly, whether it's, going to a red light sauna place or a yoga place or, whatever it is that resonates with them. They have to try to find the time to take care of themselves, because otherwise we're kind of always living in this state of, like this tension and this, you know, nervous system, it's like it's all hyped up. So I think that if we can teach people to just take 5 minutes every day and do whatever practice really resonates with them, I think that could be really helpful for pain.
Yeah, I love how you say that because I think that is so, like I was saying before, like the nervous system for a lot of people seems to be this sort of intangible thing when in reality, it's super tangible. There's a lot that, and like you said, it's a buzzword. Like people talk
Yeah.
about nervous system regulation all the time. Some people know what they're talking about, some people don't. But at
Yeah.
the end of the day, it is a reality of our modern world. And
Yes.
with, we are tend to be chronically in a state of fight or flight, even without a chronic disease that puts you in a whole lot of pain. And so when you have that on top of it, not to mention the way that endometriosis innervates itself and like actually physically is affecting the nervous system, growing directly on nerves, like that kind of thing.
Yeah.
They're so intricately intertwined, and just doing those little things. I like how you say just finding what works for you. That's often how I feel about meditation.
Yes.
Everyone always said to do mindfulness meditation, do mindfulness meditation. And I would always try to get in this routine of doing mindfulness meditations, but I would fall off because I didn't like doing them. And then I started like exploring into these other types of like visualizations and what are those ones called? Like the loving kindness, loving compassion or something like that. I love those so much more. They make me
Yes.
feel good. And like, yeah,
Yes.
mindfulness is always a part of it, but it's not like those mindfulness meditations where they're like, count your breaths. I'm like, I'm bored.
Right. It's funny. I started doing a meditation. So I started to dabble in energy healing, and I've trained to be a pranic healer. And in that training, we learned to do the twin hearts meditation, which is the loving kindness
Yeah.
meditation. And I said to them, at the beginning, I said, you know what? I cannot meditate. And they were like, what do you mean you can't meditate? I'm like, well, I can't sit in silence because I'm constantly thinking of my grocery list, nervous system's up here, right? So I'm thinking about my kids, my grocery list, like what do I have to do later? But for some reason, that particular meditation really does resonate with me. And I do find that when I do that, I'm in such a better place. So I've been, encouraging my patients to just, I recommend that one, but I do
Mhm.
say, find what works for you. Maybe just listening to sound bowls is something that's very healing to you, right? Or chimes or something like that, or mantras. I think to sit in silence is very difficult. People can do it. It's not my favorite type of meditation, but yeah, I think that's funny because I think you just have to find what works for you. There's some people who hit the gym and they, they're like, this is what I do for myself. I go to the gym 6 days a week and I'm doing, these high intensity workouts. And I always have to remind them, like, yes, that's for you and you enjoy that. But your nervous system's still up here when you're doing all those workouts, right? Because you're going from station to station and you're lifting heavy weights. You have to figure out a way to get your body to just settle. And whatever way that is, just start with 5 minutes. And I always like, I think too, part of the issue is that someone with, let's say, endometriosis, right? They go to a provider and they're like, okay, you need to do this, you got to change your diet. You have to start exercising. You have to get IVs. You have to do meditation, right? And then they get a list of 10 things that they have to do. I always say start with one thing, change one thing. And then when you get comfortable with that, change the next thing. You can't possibly change your diet, your sleep habits, your vitamin supplements, all the self-care stuff. You can't do it all in a week. So you have to go at your body's pace, but you have to have the mindset that, okay, I'm going to change some things and I'm going to do one step at a time. That way it's attainable to them,
Yeah.
right? Because sometimes you give
Yes.
somebody a plan and you're like, okay, this is your plan. And they see the 20 steps and they're like, forget it. I'm not doing it. It's too many things.
Mm-hmm.
One thing at a time is usually a
Yes.
better approach.
Yeah, I completely agree. It's sustainable. And also, I would argue that I feel like with endometriosis, with the not having a whole lot of research and a whole lot of care options at this point in time, like for the past decade plus, have been looking at myself as my own case study. And when you change all these things at once, you're doing too much. It's not sustainable. And then you're not able to accurately assess what's actually helping you
Mhm.
versus like what might not be making a difference. Because, yeah, like you said, there are certain things that there's a certain supplement that might really help one person because they happen to be depleted of that nutrient, but it's not going to do anything for somebody else who eats a diet high in that nutrient. You know what I mean? So it's like,
Right.
it's very individualistic. And when you have a 20-step plan, yeah, you're not going to have any idea what's actually helping versus what's not. And chances are you're going to get burnt out with it. So I think that's great advice. And is that how you kind of run your practice as well? Because I know with pelvic floor PT, I've been in it for quite a few months now. I have a lot of exercises that I just incorporate into like my workouts throughout the
Mhm.
week
Yeah.
because I'm up to quite a few at this point. But if she had just thrown all of those at me and been like, okay, here's all the exercises we're going to do, I never would have stuck with them. So when it comes to the way you run your practice, do you have that same mindset of like keeping it simple and sustainable first for
Yes.
patients?
So I do believe that there's still some foundation that we have to teach, right? So breath work is always the beginning, depending on what we find. If we find that it's, you know, stretching that's more, appropriate at that time, then we'll start with the stretching program. And then once the stretching program is at a level where we feel comfortable to then graduate to some basic core exercises, pelvic floor exercises, and we can do that. And then we can have them incorporated at the gym. So I always ask at the first session, what are some of the things that you enjoy doing? So somebody who does Pilates on a reformer would probably get some different exercise than somebody who does heavy weightlifting at the gym. So, I try to tailor it to what they enjoy doing, or if they play a sport, I try to like incorporate the exercises into what they're already doing and what they enjoy. Because if they don't enjoy it, they're not going to do it. So I find that if you can customize it and make it so that they will stick with it, then that would be, ideal.
Yeah, no, I love that. And I think that's so true because when there definitely are certain exercises where I'm like, I feel like proud that I'm able to do them now because I'm like, I know a couple months ago I wouldn't have been able to do this. And I guess just because of like the dopamine I get from that, I'm much more
Yeah.
likely to do those as opposed to the
Yeah.
other ones where I'm like, this is tedious. I want to switch gears a little bit, talk about a different buzzword, fascia. I
Okay.
hear about fascia all the time online. And honestly, I feel like I know what it is, but I don't think I could like give a solid definition. Can you talk about what it is and how it is incorporated in pelvic floor physical therapy?
Sure. So fascia is just connective tissue. And we have fascia from the top of our head, and it envelopes our entire body all the way down to our toes. And it's one, continuous system of connective tissue. And basically, how I like to describe it, I mean, it's probably, sometimes people, enjoy this reference, but it's not the muscle, it's not the skin. It's almost that connective tissue that's in between. So if you've ever cut chicken, you'll see there's chicken skin and then there's a chicken meat. And then there's this white, like thin connective tissue, like in between. That's sort of like what fascia is in the human body. And the role of fascia is to protect the organs, the muscles, so that there's good movement in our system. And whenever there's trauma, pain, adhesion from scarring, there's a discontinuation of that movement, right? And so then sometimes, actually there's some research that shows that a C-section scar, when we have tightness in the fascia surrounding the C-section scar, adhesion from the scar, it can actually lead to migraine headaches. And you wouldn't even make that connection because the head is so far from the lower abdomen. But because that fascia is a continuous envelope that kind of wraps around the body, you can have tight fascia in one space and then feel symptoms in another part of your body. So, with respect to endometriosis, because it's inflammatory, because there is, adhesion and pain, sometimes myofascial release can really help in those areas to help increase blood flow to the area, improve the flexibility of the muscle underlying and getting better movement in that part of the body where they're feeling pain. So, myofascial release is very gentle. It's not like a deep tissue massage at all. It's completely different. It's actually lighter and it's more sustained. So, I'm holding. If I feel restriction somewhere, I'll just kind of hold and I'll kind of glide my hand, but I'll go along with the movement. We can kind of sense with our hands what's going on. And so it's a very, very gentle approach to treating pain. So it's not super aggressive. It's not deep tissue. It's not rolfing or anything like that. But we do find that that can be very helpful, especially in the pelvis, in the abdomen, in the digestive tract, where a lot of times people will have endometriosis there, and all the way up into the rib cage and sometimes up into the shoulder. So sometimes pain can radiate all the way up into here. So that's very important to make sure that, the therapist that's working with you is not just doing internal work, that they're also doing full body assessment of what's going on and treating the areas where there's limitation.
Mm-hmm. That was a great explanation because I always say how endometriosis affects your entire body, and there's a lot of different ways. Obviously, we know it can grow anywhere,
Hmm.
but a lot of times it is contained in the pelvis. And then some people are like, okay, well, they did my surgery and it was like stage 1 and it felt really like invalidating and it's just in my pelvis, even though I have all of these symptoms up and down my body. Like, why is this happening? And that's a big part of it. The fascia and the nervous system,
Yeah.
all of these things cause pain radiating in all of these other places that you might not necessarily have lesions growing. But that was really interesting. The migraines from the C-sections, that's really interesting.
And also, sometimes we call, oh my gosh, what's the word I'm looking for? It'll come to me, referred pain. So you can have a lesion in one place or an injury in one place, and it can refer pain to a different body part that's not necessarily super close to where you have the lesion. So, it's really important for the therapist to make sure that they're doing, like I said, like a whole body assessment to see where the restriction is so that you can address that part of the body.
Mm-hmm. Yeah, absolutely. So when it comes to the chronic inflammation and tension that endometriosis patients tend to carry, how does that directly affect the movement of the fascia then, I guess, that tightness?
Yeah,
Okay.
right.
Okay.
Then what happens is if the muscles or the tissues underneath that fascia don't have good movement because they're in this tightened state, then the fascia is not moving at all either. And then over time, that can then cause limited movement or adhesion, as we would call it, right, in that area. So then it just becomes painful when they do try to move, right, because it's pulling on that tissue. So, yeah, so that's how that would be related.
Okay. Are there like safe ways to do myofascial release at home for patients or
Yeah.
does it have okay. Can you talk about that?
We teach patients all the time how to do different techniques, for to do myofascial release on themselves. And basically, it would be almost like a self massage, but we teach them how gentle it is and in what direction to pull, depending on their particular symptoms. I know people are using different things like suction, like cups and stuff like that. I think that's a little, depending on the person, can be a little bit more aggressive, but you can do gentle massage. There are definitely other things like cupping, Theraguns, different. If people use that, like do like ART with that, stainless steel blade. I
Mm,
think they're definitely gadgets that people can use. I think sometimes they get more aggressive at home because people think more is better. So, with respect to doing those types of techniques, I like doing them in the office here, and then I just teach them gentle techniques to do at home for themselves.
yeah, I think you're right. Because I have just a massage ball that I will use sometimes at home on my back because I get a lot of like tension in my upper traps and stuff. And sometimes I am like I'll realize I'll just kind of just be not paying attention. And then all of a sudden I'll like get back in my body and I'll be like, I'm pushing really hard right now. Like, I don't think
Yeah.
that's necessary.
Yeah.
But
Yeah.
you're right. You kind of think like, oh, the harder I push, the more I can like beat it
Yeah.
out of me. I'm like, that's not how it works.
Yeah. I mean, it does feel good sometimes when you find like a spot that's really tight
Mm,
and you're like digging like, the massage ball. And you can definitely use those tools. But I think once they bring the tools here, we can show them how to use it and just be very gentle at home.
yes.
Because I do think there is that mindset of like, oh, if I do it harder, if I push harder, if I do it more, it's better. Like even when we teach people to use the pelvic wand at home, I had a patient that said she used it for 45 minutes at home. It was prior to her coming into the
Okay.
office. I'm like, wait a second. I'm like, 45 minutes is way too long. That's a lot. And then she's like, yeah, I was trying to figure out why I was so sore the next day.
No.
That's why.
Yeah, 45 minutes, that's a long time.
Yeah.
I should probably use my pelvic one more often. And my PT like taught me how to use it. But yeah, you'll barely get me to do it for like 5 minutes. And I'm
Right.
just impatient. I'm an
Yeah.
impatient person.
Right. But I always say, and also when you do your wand work at home, you need quiet, you need, some, privacy. So a
Yeah.
lot of times women don't have that available to them. So I always say, like, 5 to 10 minutes tops is what you're doing with that. Don't go past that because you don't want to overwork the muscle and then end up with pain the next day.
Yes. Yeah. And while we're talking about the internal part of things, whenever I'm talking about my pelvic floor physical therapy experience online and, sharing how useful it can be for endometriosis specifically, there's always a lot of people in the comments that are like, I keep hearing about it. I really want to try it. But that internal part terrifies me, whether it's like because of trauma
Mm,
or a lot of endometriosis patients have like extreme pain with insertion and penetration, whether it's like lesions in the vagina or, adhering the vaginal wall to surrounding organs and stuff, like it can just be so painful for them and they're really scared. So, can you walk us through what happens during an internal exam? And if you have a patient who is like really not ready for that, what you can do for them instead?
So, first, I'd like to say that we don't have to do an internal exam. So, if you're a good therapist, you'll be able to assess externally what's going on and you can see in the way that they move and, regarding their flexibility, you can assess basically what's happening. And we can also assess externally. So, an internal exam is when we put a gloved finger inside the vaginal canal and we're feeling around for muscles. We're trained to do that. Please don't go to a therapist who is not trained in doing that. And so, if somebody did not want to do an internal exam, what I would do is have them lay either on their back or on their side. And I can, again, with a gloved hand and with underwear on, clothes on, I can sort of palpate from the outside. I can feel where there's tension, where there's good flexibility. And so I can and I can envision in my mind like where the muscles are and, which muscles are tight, which are not. I can ask them for a contraction. I can ask them to relax. So I can feel all of that externally. So first, you don't have to do an internal exam until you're comfortable with doing that. Secondly, so if I am doing an internal exam with somebody, I'm teaching them how to breathe first, before I start anything, because I can see how people can get very, nervous, especially if they have pain in that area. I put them in a very comfortable position so their legs are comfortable, their back is comfortable so that they're not holding any tension anywhere. And then with a gloved hand, I'm going to palpate on the outside just to see what I can feel. And then insert a finger, and then I will test, right and left side. And basically, I'm testing all three layers of the muscle. I go pretty slowly so that they're not, in any more discomfort than they already are. And then I'm basically asking them if anything hurts, if any of my pressure is relieving some of the pain that they're having, and I'm testing the strength. So that's basically the internal exam part of it. Uh, that's also part of the treatment. So if somebody has pelvic floor muscle tightness or hypertonic muscles, then a treatment would be to do myofascial release stretching, holding on trigger points in the pelvic floor. And so sometimes people will ask me that question, like, are you just doing the internal exam on the evaluation? Or am I going to have to do that every time that I come? And my answer to that is always, whatever you're comfortable with, but it can be very helpful to do internal work so that we can release some of those muscles. And then I'll talk to them about a dilator or a wand, and then talk to them about purchasing that so they can bring it in and I can teach them how to use it. But a skilled therapist should be able to do an external assessment if you ever come across a client that, really is not comfortable with an internal exam. What's that saying? Like, there's 100 ways to skin a cat. I kind of feel
Something
that.
like that. Yeah. Yeah.
Kind of feel that,
Yes.
if someone's not even sometimes people are not even comfortable with laying down. So if they've had sexual trauma, they won't lie down on the table. So I'm totally fine with doing an exam in standing. I could do it, side lying. So I feel like you always have to meet your client where they are and get them the information, and then they can kind of process it later on. And sometimes they come and they do the internal, they're like, oh, it's not so bad. I thought it was going to be, you know, uh, more painful. I thought it was going to be, more uncomfortable. So I think it's all in the way that you set it up and the way that you do it so that you have the patient feel comfortable.
And it's not the whole time, right? Like, I
No.
think a lot of people book an hour-long appointment and they think that it's gonna be that for the entire time. I'm
Right.
like, that would be really uncomfortable, but there's a
Yeah.
lot of other stuff.
Yeah, yeah. So usually our appointments are structured like, so someone will come in. If it's a new patient, I'm getting the thorough history and then I do the exam on the table. The treatment, when they come in after that, they come in, they'll kind of tell me where they're at with the exercises that I gave them and whatever techniques I gave them for home. Have they been feeling since the last session? So that's like a few minutes. I typically work where I do my manual therapy first. So we'll do stretching, we'll do the internal stretching if that's necessary. And then the last part of the session is either breath work or we're going out into the exercise area and then we'll get on the mat, we'll get on the reformer. We have a Pilates reformer here. So we'll do exercise to help strengthen their core because when the core is strong, when their abs are strong, it supports their back and it supports their pelvic floor. So a lot of times when people have tension in their pelvic floor, it's because their core is weak. Their core and their back are weak. So we try to strengthen as we're keeping the pelvic floor flexible, we're strengthening, the front part of the body and the back part of the body so that it will then protect and help out the pelvic floor that's at the bottom.
I definitely like, now that you're saying this, I'm kind of thinking the more that I have been strengthening my core, the less back pain I've been
Mhm.
having. Cause that's one of my like major just pain up and down my back, depending if I'm ovulating, menstruating, slept weird. And back problems run in my family too. Like I've just got, so yeah, the more I strengthen my core, the less that
And
bothers
people
me.
forget that it's connected, right? So
Mhm.
just because you have some people will come in for just a pelvic floor issue, when in reality, our pelvic floor is connected to our diaphragm, our abdomen, and these little muscles in our lower back. So when that system works properly, each section will help out the other section. But if there is dysfunction in one of those areas, or there's weakness in the abdominals, or it's a postpartum woman who has a diastasis, abdominal separation, or weakness from pregnancy, and then you have back pain, and then you have your diaphragm that's not expanding because we're not breathing properly, that whole system is not working together. So we have to figure out a way to get that system to work together so that it will support the pelvic floor and not work against it.
I love that. The interconnectedness of the body, I think, is something that we tend to forget a little bit with our modern medical system. It's set up to be quite reductionist. And I talked about this with Dr. George too. Like, when I'm having a heart attack, I want a cardiologist, a heart surgeon, like in the room. But when it comes to something systemic and chronic, like endometriosis and chronic pain from endo, I want something that's actually taking the entire body into account and how all of these things are working together. So that's really great. Wonderful explanation. Yeah. Yeah. Well, this has been phenomenal. We are coming up on the end here. I have one last question that I like to ask all of my guests at the end of our interviews. If you could rewrite the health class curriculum that every woman deserves, what would your first lesson be?
My first lesson would be to learn your anatomy, learn about your cycle, learn about hormones at an early, early age, because that will give you knowledge and power as you go through different stages of your life. And you won't accept sorry, that's just how it is, as an answer, which I think too many people are hearing at the moment. So to me, the most important piece in this is to educate as early as possible. And I do think, when it comes to women's health care, and I've been in it now for a while, it's so disappointing to me that we are not giving the education, we're not giving the care, we're not giving the attention to women at, all different stages of life, right? I know we're talking about endometriosis, but, when we talk about, period care, in puberty and in teenagers and young adults, then pregnancy, postpartum, then perimenopause, menopause. There's so many things that, our bodies are so amazing that we go through all these changes. Why are we not helping women when they're screaming for help? Now, like I said, like midlife and menopause is having a moment right now, which is great. And you still have doctors that are telling patients, no, hormone replacement therapy is not going to help you. It's going to actually give you cancer, which is such outdated information currently. And or there's no other answer, right? So if that's not the answer, then what is the answer? And then they don't have answers for you. So it's so frustrating. So to me, I think education at an early age, learn about what's going on in your cycle. Don't go blindly into an appointment not knowing what's going on, because then you can ask the questions. Then when someone says to you, sweetheart, sorry, this is just how it is, then you can come back and say, then what is the solution? Tell me what the solution is. What's another way that I can help myself? And if they can't help you, then it's time to move on and go to a different provider. Because I think that, we do get very connected and attached to providers that we've had for a long time. And I hear that a lot, like, oh, they delivered my, 3 of my babies. I love them. I love them. I love them. And then they go through a change, or they're going through pain, and they're like, sorry, this is just what happens. And I'm like, that's not an appropriate answer, right? If you had the education and the knowledge early enough, then you would know that that's not the right answer. And then you would keep going until you found somebody to help you.
Yeah, knowledge is power. It's how you become empowered. And even like what you were saying in the beginning of our conversation of teaching children the correct anatomical names for things, and enough with the euphemisms and stuff. Like, it is so important, and it seems like a small change, but language makes the biggest difference. I have seen this in my own life and in classes that I took in college when I was studying neuroscience. Like, language makes a huge difference.
Yes.
And what we are saying, and the thing, like the way that we are referring to our bodies and our cycles, and having that knowledge and being able to like accurately have a conversation about the female hormone cycle with a provider makes an insane difference in the healthcare that you get, the way that you're able to advocate for yourself. So that would be life-changing. Yeah.
And I also think we have to take away the shame. It's not shameful to talk about your vagina. It's not shameful to talk about your period and your cycles. Every single person who has a vagina and a uterus is going to have a period, right? At some point in their life. So why are we making it this hush hush thing that we cannot talk about? It's so ridiculous. And women I think we make up 51% of the population right now. So
yes,
we should be talking about better ways to take care of the women on this planet.
Yes. And not only are we, over half the population, but our cycles are the only reason that the entire 100% of the population exists in the first place.
That's
so
right.
It's like, why wasn't this something that you would be prioritizing in healthcare, in culture, in research? It just doesn't make a whole lot of sense.
Yeah.
So yeah, I completely agree. This was such an awesome conversation, Rachel. Thank you so much for being here.
Thank you so much.
Where can people find you?
So we're on Long Island. We have 7 locations. It's Lotus Physical Therapy, and we have a website. It's lotusptlongisland.com, and we'd love to see anybody who's watching. Just know that you have a place to come to, even if it's just to get your questions answered.
Awesome. And I will make sure that is linked for everybody in the show notes, as well as all of Elisara's information as well.
Great.
I'll have that linked below.
Perfect.
Thank you so much.
See you soon.
See ya. Class dismissed. Bye.